on transgender people and PrEP. So it's around key considerations moving forward. And here's the outline of my talk. I will talk a little bit about HIV and PrEP snapshots in Asia and the Pacific, and I will share with you about the lessons learned from the PrEP program that we have been implementing in the past 10 years in Thailand. And I will, based on the lessons learned, I will talk on the barriers to PrEP uptake among transgender women, especially in Thailand, and also strategies to address those barriers. And I will focus a bit about the implementation considerations to PrEP options among trans people as well. And I will end my presentation with a few key takeaway messages. So according to the data from UNAIDS, you can see that there was some 7% increase in HIV new infections among transgender people between 2010 and 2022 in our region, Asia and the Pacific. And high HIV prevalence among transgender people in cities and in some certain geographic locations in our region between 2016 and 2022 was observed. You can see that on your left-hand side, the HIV prevalence among trans people was around 2%, and on your far right, it was higher to 37%. You can see that on your right, the geographic location or certain city representing coming from Indonesia, Malaysia, India, and also in Cambodia. So it's really showing that the alarming HIV prevalence among this country needs special attention, especially among transgender people. And here's this slide shows you about the PrEP snapshots in our region in Asia and the Pacific. So based on the data from UNAIDS, you can see that only 200,000 people used PrEP at least once in 2023, compared with the target in our region, which anticipated to have 8 million people to have PrEP, to access to PrEP by 2025. So it's really showing that it was less than 2% of the people actually used PrEP in our region. So it's really alarming that PrEP uptake was relatively low in our region. And what about in Thailand? So this slide shows you about the PrEP landscape in Thailand. So you can see that in 2022, the national PrEP target in Thailand was 144,000. So of those, 100,000 are around men who have sex with men, and almost 10,000, we anticipate that transgender women would access to PrEP. But in reality, according to the data in 2023, we found that only 31% of the key populations in Thailand were able to access to PrEP services, which is still far away in order to accelerate an end to the AIDS epidemic in Thailand. And on your right-hand side, it's really showing that the majority, or almost half of the PrEP users in Thailand actually coming from the key population-led health services, or the key population or the community-led health clinic in Thailand. And I'm very glad to see that some of the community-led representatives are also attending this session as well. For example, the Rainbow Sky Association of Thailand, which is the largest LGBT-led organization, and Service Worker in Group, which is another sex worker-led organization in Thailand. And they expand the PrEP program in their high HIV priority provinces in Thailand. And right now we have only around less than 20 key population-led clinics in Thailand, but we were able to cover to more than half of the Thai PrEP users in the country. So it's really showing that the model of having the key population-led PrEP program is very promising to distribute PrEP or bring PrEP to those who are in need. And when we're looking at the data, we found that transgender women in particular, they decline to get PrEP. And we're looking at our data, the reasons why these transgender women, they decline PrEP when they first offer. So on your right-hand side, we got the data from around 500 transgender women who were eligible to get PrEP, but they were not interested in taking PrEP. And we asked them why they were not interested or why they declined PrEP. On your right-hand side, you can see that around 42% they said they were not at HIV acquisition risk. 28% they said they do not like taking pills. It's around pill burdens. And another reason showed that around 12% they said they had the fear of drug-drug interaction and the side effect. And the remaining reason was around they were not ready or they were not interested. They wanting to use condoms and they fear of being stigmatized or being judged by any other community members. And when we're looking deeper up from the data that we actually collected from the transgender women, from those who said they were not at risk of HIV acquisition from your left, we found that those who reported that they were not at risk for HIV acquisition, we found that around almost half of them, they had condomless sex, and around 16% they reported having multiple sexual partners. And we have seen like small percentage reported engaging in sex work and ever having STI history. And the reason number two, they reported that I always use condom or I wanted to use condoms only. But we looked at the data that we collected from these women, we found that 34% of them, they also had condomless sex as well. And on your right-hand side, the reason number three, they said they do not want to take any pills. We found that more than half of them, they actually did not have, they had condomless sex in the last month that they reported. And the second reason, around 30%, they reported having multiple sexual partners as well. So we thought that there might be something wrong when our healthcare providers, especially the key population lay providers at the key population-led clinic, they try to offer PrEP to these women. And we found that many of them, they said they were not interested, or they said they were not at risk of HIV acquisition. And when we analyzed the data, we found, I think it's similar to what Professor Van der Loof shared from the experience in Amsterdam. I think it's similar to what we learned from transgender people, especially transgender women in key population-led service clinic in Thailand. On your left, you can see that these are the barriers to access to PrEP services among trans people from the key population-led clinic. So we found that drug-drug interaction between PrEP and feminizing hormone was one of the concerns. Low self-perceived risk, stigma associated with PrEP, associated with HIV, or associated with transgender identity or sex work was one of the reasons as well. Pill burdens, transportation costs due to frequent clinic visits, and the high cost of the PrEP. Because at that time, PrEP was not supported or subsidized by the national healthcare system. And on your right-hand side, we also talk about the strategies to address PrEP barriers among transgender people. So we talk with the key population lay providers who actually work at this clinic. What should be the strategy that we should address these barriers? So we found that we should have the data around drug-drug interaction between PrEP and feminizing hormones. And we also need to launch the PrEP awareness raising campaign among these women, because we learned in the past that most of all of the PrEP campaign was only focusing on gay men and other men who have sex with men, leaving transgender women and other vulnerable populations behind the PrEP campaign in the countries. And we also need to train our healthcare providers. We also thought that we also use risk-based counseling when we would like to offer PrEP to our transgender women. But there was the need to develop a gain frame or positive frame counseling curriculum that to make sure that they are empowered and they are knowledgeable of their own health. And we also think about like, we should suggest even given PrEP after we conducted the pharmacokinetic study, so we would see the data, how it was, and then to increase the PrEP option. I think it's really emerging from the transgender community, why we only have to take daily PrEP, or we only have the PrEP alternate. Why don't we have any other PrEP alternatives available in the country? And we also talk about how we are going to integrate telehealth, mobile health, and HIV self-testing, linking to PrEP initiation, continuation, and PrEP restart as well. And while we are doing the implementation research around PrEP, there would be a way to use the data to inform the advocacy strategies to include PrEP in the universal health coverage program in our country, Thailand as well, which leading to sustainability. So what we did, I would like to share with you that I think in 2018, we actually conducted the first pharmacokinetic study, or a PK study, looking at drug-drug interaction between feminizing hormone and PrEP using FTC and TDF as PrEP among transgender women. And this study was actually led by Dr. Akrin, our co-moderator. And based on this data, we found that transgender women who are on feminizing hormone can take PrEP while they are on feminizing hormones. And these data need to be translated into lay languages. And we actually use this data to inform the development of the first transgender specific PrEP campaign in Thailand. So we developed this campaign called PrEP in the City in order to make sure that these messages is really targeting to the transgender communities in the country. So we use the very positive frame messages around PrEP, and we work with the 4 transgender women influencers who are very famous in the country, and they represented different characters or lifestyle of the transgender communities in the country in order to promote PrEP messages in their own communities. And in addition to that, IHRI also conducted a study around PK study between looking at drug-drug interaction between FTAF and feminizing hormone among transgender women as well. And recently, also Dr. Akrin did a study looking at the PK drug-drug interaction between FTAF, TDF, FTC, and with masculinizing hormones among trans masculine people. And the data has already shared in some of the international conference last year. So I think it's really needed. This was actually the research question actually raised by the transgender community. But after we launched this first PrEP in the City campaign, we were able to observe increased uptake of PrEP services among transgender women in Bangkok. And it's not only at my clinic, the Tangerine Clinic, but other key population-led clinics and other clinics that offering PrEP from the public hospital in Bangkok. They were very able to see the increased uptake of PrEP services among transgender women as well. And here's the communication materials that we use to promote PrEP in the City campaign across Bangkok metropolitan area. So we use the materials to advertise in the bus or in any other platform that around the public transportation as well to promote the PrEP services. However, it was not easy, I would tell you. When we approach to any media platform or any other department store to promote messages around PrEP with transgender women, some of them they rejected my request to promote PrEP because of stigma and discrimination. So I think, to your knowledge, many of you may have perceived that Thailand is actually the paradise for LGBT people, but in reality it's untrue. With stigma and discrimination actually remains in my country. So what we did at the clinic level, we actually talked with the transgender clients and the lay providers who are members of the transgender community as well. We actually developed a training curriculum focusing on the gain frame counseling messages. We asked our transgender clients what kind of messages that they did not want to hear when we offered them PrEP. And that's why, and what kind of messages that they really want to hear, or what kind of messages that are very empowering or motivational for them to be interested or to consider to get PrEP. So we talk with the transgender communities, and then we come up with a set of the training curriculum on gain frame counseling for PrEP among transgender women. And on your right hand side, you can see that this is one of the very empowering messages that we come up with. Planning for sex is not always possible. Taking PrEP means you are always prepared. We don't ask them about how many partners do you have. Have you ever had any STI history? Do you engage in sex work? Or do you have lots of multiple partners in the past? We're not going to ask them that question, but we provide them educational messages, empowering messages, and it's their own decision to make their informed choice whether or not PrEP is right for them. So I think we also, after we implemented these gain frame counseling messages at the Tangerine Clinic in 2020, we found that around 1,200 transgender women who were not on PrEP, they visited the Tangerine Clinic, and the median age of these women was 26 years old. And we found that after we offer, we integrate gain frame counseling messages into the counseling messages to the transgender women, we found that 35% agree to get PrEP after we providing gain frame counseling, comparing with less than 10% before we try to offer PrEP to our transgender women at the clinic. And 80% of those who agree to get PrEP, they were new PrEP user, or they initiated new PrEP. And 20% they decided to restart PrEP after the previous discontinuation. And we also found that 20% of the transgender women, they did not perceive themselves to be at risk of HIV acquisition. And around 40%, they reported risk behaviors, and they actually were diagnosed with an STIs. So, and 2 years ago, we thought that how are we going to increase more PrEP uptake, especially among transgender women, and we actually conducted an implementation study by using an HIV self-testing linking to PrEP services. So we conducted a small study at my clinic, the Tangerine Clinic. So we did use the HIV self-testing for PrEP initiation and PrEP follow-up as well. So starting from your left, you can see that in terms of PrEP initiation, we would do almost everything through telehealth channel. So we're going to provide like telehealth counseling with the transgender women client via the LINE application. For those who don't know what LINE is, it's actually like WhatsApp application where we can do video call between the clients and also the providers who are working at the clinic as well. And if the clients agree to get PrEP, we're going to send the HIV self-testing kit bundled with the self-sampling collection kits for chlamydia and gonorrhea testing. And this will be delivered to the Grab bike in Bangkok. So you know that the traffic in Bangkok is really bad. So that's why the Grab bike or Grab delivery is really a promising strategy to bring the HIV self-testing and STI self-collection kits to their home. So after we sent the kits to our client's home already, we conducted a telehealth post-test counseling, and if they agree, and if the screening test was non-reactive, we're going to send them the first bottle of PrEP to their home by the Grab again. And then you can see that, and then this Grab man will also collect those sample, the specimen that they collected for chlamydia and gonorrhea testing back to my clinic, and they're going to process the testing at my clinic, and then the result will be shared with our clients, actually mostly on the same day, or at the latest is on the next day. And in terms of PrEP follow-up, we actually use the same process as well, but we increasing number of PrEP bottles to our clients as well. And we found that it's really interesting to see the data from the implementation study. So in the middle is the data that we analyze from transgender women who receiving HIV self-testing linked to PrEP. So you can see that for those in blue bar, representing transgender women in the middle who screen non-reactive after using HIV self-testing. And we found that 27 of them, they agree to get PrEP services, which was kind of similar percentage as the clinic clients who receiving PrEP. And for those who receiving PrEP, it's very exciting to see that 80% of them, they are new PrEP users. And the remaining, they are PrEP follow-up and PrEP restart client. And you can see that when we compare the data with cisgender women and men of sex with men on the left, we found that HIV self-testing can link new PrEP users among MSM to 40% and among 56% among cisgender women who decided to get new PrEP. So it's really another promising strategies to deliver HIV self-testing kits to this key population, especially transgender women. So, and what about other PrEP options? I know that you learn a little bit at the lunch and symposium next door and then this data actually shows you about the regional PrEP discrete choice experiment survey that we conducted in 13 countries and territories in Asia and the Pacific called PrEP-April study. So we analyzed the data about the preferences of the MSM and transgender women towards different PrEP options in our region. And we found that on your left, the green bar represented transgender women, yellow represented men MSM who are from Asian low middle income countries, and gray represent MSM from Asian high income countries, and the light orange represent those MSM who are from Australia. And it's interesting to see that around 32% on your left, you can see 32% of transgender women in 11 countries in our region, they said that they prefer daily oral PrEP. While 20% of the transgender women, we found that they prefer injectable PrEP, which used to be administered every 6 months, or in this case is lenacapavir. And in terms of MSM who are from Asian lower middle income countries, 22% they prefer daily oral PrEP, and around similar proportion, they still also prefer event-driven oral PrEP. And it's also interesting to see that we have observed a very low preference rate among MSM and transgender women who said that they prefer injectable PrEP every 2 months. So this study was actually conducted in 2021 and 2022. So if their different preferences may be varied or may be changed over time as well. So it's really showing that if we have more options on PrEP, it would be possible to increase PrEP uptake among these key populations in our region. So, in terms of implementation consideration for PrEP options, so I think it's really important to use this actually framework when you plan or design your PrEP program in your setting. So, for example, I am a transgender woman, and when we talk about frequency of product use, on your left-hand side, you can see that right now in the pipeline, we have oral TDF FTC using as PrEP, injectable PrEP, or cabotegravir, which will be administered every 2 months, lenacapavir, which will be administered every 6 months, and we have another investigational drug, which is oral MK-8527, which anticipated to use once every month, which is oral tablet. So when you talk about this, what about the perspective of the users or the clients when we talk about different PrEP options? For example, like myself, if we talk about frequency of use, of course, I myself probably prefer injectable lenacapavir because it's more convenient for me. I don't like taking pills every day because I have lots of vitamins, lots of supplements, lots of feminizing hormone already. So I put big small dark green in here. It's actually coming from my own perspective only. It doesn't represent any perspective from other key populations in some administration. So I'm thinking like, okay, having oral daily PrEP pill would be very easy because I can manage my own health. I can take it every day. But what about injectable? Oh, I have to go back to the clinic every 2 months or every 6 months, right? So it may be difficult, inconvenient for me to go back and forth with the clinic, especially in the setting which has been in the long queue or where stigma and discrimination remains one of the barriers. What about integration with STI testing? Oh, I normally go back to my clinic every 3 months to screen STI, to collect my, specimen for chlamydia and gonorrhea testing. But what should I do with lenacapavir? What should I do with, other PrEP options? So it's raised me a concern. What should I do with the STI? Because STI is also my concern as well. What about viral load testing? If I'm, in the acute HIV infection or have a early detection on HIV infection, would those key population-led clinic have to have any machine that can, detect early HIV infection as well? What about the cost that I should have to pay? In terms of adherence support for effective use is also another concern. We talk about adherence and persistence of PrEP use as well. So we put different, emoji here to represent the perspective of the clients, which you as a healthcare provider have to consider when you provide PrEP options or counseling to your client. What about drug-drug interaction? We still have the data from daily oral PrEP on TDF-FTC, and Dr. Akrin led another study on FTAF with the feminizing hormone as well. So what about the upcoming PrEP options, lenacapavir or even MK-8527? And lastly, what's about the cost that I have to pay if my country doesn't support PrEP as a national program? What about the generic PrEP products? Would the Thai FDA or the government pharmaceutical organization in my country would buy in these kind of products in order to bring down the epidemic? I put Angry Bird on the right because I know that cabotegravir will be introduced in my clinic likely early in March this year. And I know that the price is very costly. So it's really prevent lots of people, including myself, to access to this product. So this study is actually led by Andrew Hill and his team, and it was actually presented at the AIDS conference in Munich last year. They they did a price comparison of different PrEP options. And you can see that on your left, the oral TDF-FTC was around $40 per year. Then, in terms of dapivirine, vaginal ring, it was around $156 per year. What about cabotegravir? It was, it was estimated that, but it's likely to be that the price in Thailand would be around 2,700 per year, which was 20 times higher than oral PrEP on your left-hand side. And in South Africa, lenacapavir was introduced as to be $180, which is 5 times higher than oral PrEP as well. So what about lenacapavir? We still don't know, but it was predicted that it would be around $100 per year. And modeling research indicated that the price of lenacapavir could decrease to $100 per year if produced in quantities sufficient for 1 million people. And in addition to that, the cost can be dropped further to $40 per year, comparable to oral PrEP, if lenacapavir is used by 10 million people annually, while the company is still maintaining a 30% profit margin as well. So, in conclusion, we learned that we should think about what should be the strategy. So the implementation strategies to demedicalize, simplify, and differentiated people-centered PrEP is really actually facilitate access to and uptake of PrEP among key populations, including trans people. Second, increasing PrEP options actually enables clients to be able to make their own informed choice, how to introduce PrEP options leading to their own choice. And lastly, we as healthcare providers, policy makers, community representatives, or HIV program managers in your country, we need to stay updated and to be alerted about upcoming PrEP options and the timeline availability to plan for real-world implementation. This will ensure timely preparation of a country's policy, service delivery system, guideline revision, payment mechanism, as well as the regulations, how to make sure that PrEP services we bring to those who are in need in our country. And I would like to acknowledge all of these organizations, funders, and community organizations in my country for having made the PrEP works in my country possible. Thank you very much.
Thank you very much, Happy Rena. So again, if there's any question, please walk to the microphone. I think we have time for one question perhaps. And you keep citing me about the studies, but I mean, if without you, we can never do those studies. So we have been, I think, did all the PK studies in Thailand about drug interactions between fundraising hormone therapy and
maybe
and
you
PrEP.
can provide like a little bit of,
No, not really.
PK studies.
Okay, but anyway, it's nice to see that our findings, your findings can drive the implementation here, at least in Thailand. So, I think I may have asked one question of yours, because you mentioned about, I like the way we advocate, the way you advocate the bus or the public raising awareness, but you also mentioned about there are obstacles that you have to overcome.
Yes.
I think it would be great for us to learn from your experience, like how, like firstly is how did you overcome those obstacles, and the second thing is that try to keep in the theme of our region, Asia Pacific, which are very, very diverse culturally, religion as well. What is your suggestion, perhaps, or comments in terms of upscaling PrEP use among trans women or perhaps trans population in other countries as well?
I think based on the lessons actually we learn from our clients, we learn from our community. This is our strength because they are actually the users, right? So I think we have to learn from them. We have to ask them about their satisfaction, about their awareness or preferences, and listening to the community is really help you to design or improve your service provision, or even it can lead to any research question that will be useful for them at the end. So I think these kind of barriers, actually I learned from myself. As a trans woman, I learned that why I offer PrEP in 2015, I remember at my clinic, but it took me a few years later to decide to be on PrEP. So even myself, I can't even change my attitudes about PrEP. So there should be something that we are not doing good enough with our clients, with the populations we serve. And I would like to emphasize that when we ask the community, we would know what kind of the best way to bring PrEP services to their community, to bring the services to their hand. For example, in Thailand, we learned that half of the Thai PrEP users in the country coming from the key population-led clinics, where we train MSM, we train trans people, we train sex workers to become a counselor. They do the finger prick blood collection. They would be able to give the first bottle of PrEP to their clients with the support from the physician through telehealth channel. I believe that the public hospital do not want to have lots of clients to wait for a long day, and they actually don't have any problem, right? They're not those who are in need of your help. But how are we going to do like deliver task shifting or task sharing strategies to the key population and believe in their capacity and work together shoulder by shoulder in order to strengthen the healthcare system in your system? So I think, and self-care is another strategy that is very emerging in our community, how we can promote self-testing. So they would know right away whether PrEP is right or wrong for them. So HIV self-testing is another successful component, but it needs to be scaled up as well.
Okay, thank you very much, Rena. So that's the first half of our session this afternoon, and there's a break outside of the room. So we will be back here at 3 p.m. for the remaining two speakers about substance use and mental health related issues. See you in 3 p.m.